Friends, so today we are going to discuss regarding invasive fungal infections. And as we know that invasive fungal infections are increasing in our clinical practice, and this is attributed to the expanding population of high-risk individuals, patients who are immunocompromised, renal transplant recipients on steroids, critically ill patients on broad-spectrum antibiotics. This is all resulting in an increase in the high risk patient population or the susceptible host. Now, the IFIs are also increasing, and this is attributed to the advances in the diagnostics, which includes radiology as well as the microbiological test, histopathology, as well as the biomarkers. So, today the focus is going to be on invasive candidiasis, and I'm going to explain this with the help of few cases. Hi, I'm Dr. Neha Gupta, founder of NG Swastha, and with close to 2 decades of experience in infectious diseases from world's best hospitals, empowering our patients to overcome their infections and lead a healthy Swasth life. I'm also Secretary of Clinical Infectious Diseases Society India, and I'm attached with Fortis Memorial Research Institute, Gurugram. So before I begin, I'm going to ask you all this particular very important question, which is that which IFI, invasive fungal infection, has been named after India's very own fungal legend. Now, this is a tribute to one of the pioneers in invasive fungal infections. And so, which invasive fungal infection has been named after India's very own fungal legend, whether it's Candida, Cryptococcus, Aspergillus, or none of the above? The answer is it is Cunningamella arunaloke, which has been named after the professor Dr. Arunalok Chakrabarty, and this was a new species identified from India, resulting in a disease in an immunocompetent individual. Now, with this, we shift gears and move on to invasive candidiasis. So, this is a 74-year-old gentleman with peripheral vascular disease, and he had this atherosclerotic disease of the abdominal aorta. In 2013, he presented to us with septic shock with bilateral gangrene of both the lower limbs. He was initiated on meropenem. Subsequently, as a part of source control, he underwent above knee amputation of both the lower limbs, and the amputation pus had grown Pseudomonas aeruginosa. Now, this patient was initiated on colistin and tigecycline as he was having septic shock. Now, he improved, but 10 days later, he again developed drowsiness, hypotension. There was leukocytosis with the counts jumping up till 27,000, and he had to be put on the inotropes. At this point, an infectious diseases reference was sought. So, what is the most appropriate next step in the management of this patient? Send the blood cultures from the peripheral percutaneous puncture. Send blood cultures only from the central line. Send blood cultures from the central as well as the peripheral line. None of the above. So the correct answer is, or the most important next step in the management of the patient is the clinical examination. And whenever there is sepsis, we need to identify what exactly is the site of infection and then choose our antimicrobial therapy accordingly. So the amputation site of this patient was absolutely normal. It was without any pus discharge. However, this patient had a central venous catheter which was in place for almost 17 days, and there was exit site pus which was present. So we quickly took the gram stain of this pus, and at 6 p.m. in the evening, I went to the microbiology lab, requested them to make the gram stain, which revealed that it showed this budding yeast cells. Now, this is important. Now, the Candida can also be a colonizer of the skin, but when there is pus, there is a clinical infection which is seen, then this becomes important. And when we look at the patient is has been critically ill, has been on broad spectrum antibiotics, both colistin and tigecycline, which will eradicate most of the bacteria and will select out candida. And this is what has happened in this patient. Now, again, the importance of clinical examination and the clinical implication is when there is a central line which has got exit site infection, this is the source and it has to be removed. So the central venous catheter should be removed ASAP when central line is the source, especially if the patient is hemodynamically stable, and it can be removed safely. However, always remember that the decision of removal of the central line again has to be individualized based on the severity of infection as well as presence of other venous access, whether we can retain the catheter with antifungal lock therapy, and whether the patient is neutropenic or non-neutropenic. If it's a neutropenic host, then there is a possibility of candidemia as the gut being the source, whereas in a non-neutropenic patient, definitely most of the times it is the central line which is the causative agent or the cause for candidemia in a non-neutropenic patient. So now that we know that the septic shock is because of candidemia, which of the following is true? Should we start fluconazole with a loading dose of 800 milligrams followed by 400 milligrams per day? Start echinocandin? Perform further examination like a ophthalmic examination to rule out any metastatic endophthalmitis after 1 week. Duration of therapy of the antifungal is going to be 14 days after the last negative blood culture. So which is the true answer? The true answer is definitely that we must start with the echinocandin, and the reason is that fluconazole can be used in a patient who has a mild illness, so non-critical ill patients, and in patients where we are suspecting it to be a fluconazole susceptible isolate, or if suppose there is a culture positive and the DST is available, then for mild illness, not critically ill, no hypotension, we can start with fluconazole if DST is showing fluconazole susceptibility. However, empirically, when we start, because in our country, because of the local epidemiology, as there is a very high incidence of azole resistant Candida isolates, especially Candida auris, empirically it will be the echinocandins which has to be initiated. And echinocandins are definitely the first drug of choice, the initial therapy, which are to be started, and later on, once the patient stabilizes, de-escalation to an azole can be considered after 5 to 7 days of therapy if the patient is stable. The isolate of Candida is susceptible to azoles. The repeat blood cultures are negative after the antifungal therapy initiation. Coming to further workup, which includes ophthalmic examination, that should be performed within a week of candidemia, especially persistent candidemia. And otherwise, this is again becoming a gray zone. There are some recent literature which suggests that maybe as the incidence of Candida endophthalmitis is less, then it may not be done. However, if it has to be, it should be performed only after within 1 week in case of a non-neutropenic patient and a neutropenic patient who's having neutropenia. It should be done after the recovery of neutrophils. That's when the endophthalmitis will manifest in a neutropenic patient. Again, endocarditis also needs to be ruled out in a candidemia patient with candidemia, and the duration of therapy is 14 days after the last positive blood culture. So once you start, there is a culture which is positive, and we start the therapy and we have repeated the culture. So the last positive blood culture should be taken as the first uh, day of the therapy. So here it's very important to understand that the follow-up blood cultures have to be done every day, or every day it has to be performed. Now, this is a very important global guideline for the diagnosis and management of candidiasis, which is an initiative of the ECMM, the European Society of Medical Mycology in cooperation with the Isham and the ASM group. And it's really, we're proud to have Dr. Rajiv Suman sir, Dr. Tanu Singhal, and Dr. Aruna Loki Chakrabarti as a part of this. Now, the guidelines, this this is a snapshot of the guideline where they mention that if there is candidemia without organ involvement, we must consider local epidemiology and review treatment decisions in the light of susceptibility testing results. So the first line therapy is Anidula fungin, which is 200 milligrams once daily on day 1, followed by 100 milligrams from day 2 onwards. Caspofungin, which is 70 milligrams loading, followed by 50 milligrams OD. Mica fungin is 100 milligrams daily. So there's no apparently loading dose for mica fungin. We also have this new echinocandin, which is a long-acting echinocandin, which is rezafungin, and the dose is 400 milligrams on in week 1 and then 200 milligrams weekly. Now, subsequently, the other choice of agents can be fluconazole, voriconazole, and liposomal amphobi. If you're starting fluconazole, then it is for mild illness, for azole susceptible isolates, and the loading dose is 800 milligrams followed by 400 milligrams daily. And voriconazole, the dose is 6 milligrams per kg loading dose on day 1, followed by 4 milligrams per kg 12 hourly on day 2 onwards. So on day 1, it's 6 milligrams per kg 12 hourly, followed by 4 milligrams per kg 12 hourly. Liposomal amphobi for cantidemia, 3 milligrams per kg. For mucormycosis, it can be higher doses, like 5, usually 5, or some cases, maybe even higher doses can be given if it is other fungi like mucormycosis. There is also a marginal recommendation for isavuconazole. However, as clinicians, we must remember that isavuconazole is a drug with very high volume of distribution. So it has very good tissue penetration. However, the serum concentration is low. As a result, isavuconazole should not be used for candidemia, and there have been failures. It has been found to be non-inferior to the echinocandins. Coming to the source control, which is very important for the management of cantidemia, central venous catheter removal should be considered ASAP as early as possible, and daily follow-up cultures until 3 consecutive negative days should be done. Now, if suppose the blood is positive on day 5, then we must look out for a source, whether it is a central line which has not been removed, or septic thrombophlebitis, or an intra-abdominal source. All this uncontrolled source has to be investigated and um, and um, and looked into. Then subsequently, if suppose there is persistent candidemia without any source, without um, even after doing proper source control, then we must or we can consider switching the class. So here, liposomal amphobi 3 to 5 milligrams per kg per day, or voriconazole, fluconazole are the other treatment options which can be considered. And the duration of therapy is 14 days after the last positive blood culture. Now, part of management of candidemia also includes antibiotic stewardship. So we have to see the patient as a whole. And when we looked back at the culture report of the patient, which like the pus had grown Pseudomonas aeruginosa, although the tick marks have been done for colistin and meropenem, but if we look at this, this is also susceptible to ceftazidime and ciprofloxacin. And this is because this patient was at home and had developed this atherosclerotic gangrene, which got secondary infection with Pseudomonas aeruginosa. So it was like coming from the community. So that's why we have this susceptibility here. And in a patient where Pseudomonas aeruginosa is susceptible to ciprofloxacin, or ceftazidime, these two antibiotics can be used rather than using broad-spectrum antibiotics like colistin or digicycline. And that is why the broad-spectrum antibiotics were discontinued. So the checklist for Candida management in the ICU, and I've made the simple mnemonic which includes B, C, D, E, F. B for blood cultures, which has to be repeated every day for 3 negative blood cultures. C for central line. D for de-escalation or discontinuation of the antibiotics. E for the echo, and F for the fundus examination, which has to be done within 1 week for a non-neutropenic patient. In a neutropenic patient, it has to be performed after the recovery of neutropenia. So the take-home message is that it's important to have a daily check on the invasive devices, whether it's needed or not needed. There has to be inspection of the exit site also on a daily basis, and we must send appropriate samples, pus, node swabs, and blood cultures, which should be on equivalent, which should be in good volume, 3 sets ideally, otherwise at least 2 sets, 1 set from the central line and 1 set from the peripheral percutaneous puncture should be done. And if we are suspecting infective endocarditis, then 3 sets, half an hour apart, are the recommendations. Now remember, even with this, there is limitation of sensitivity of Candida in the blood cultures. The blood cultures actually just have 50% sensitivity, and that is why it becomes difficult to diagnose it. And there is also a role of clinical prediction rules as well as biomarkers for the diagnosis of invasive candidiasis or candidemia. Now we will move on to another case. This is a 72-year-old gentleman with diabetes with infective endocarditis with CCF. And infective endocarditis was a culture negative infective endocarditis. This patient had a central line. He was intubated and he was, however, stable at this point on the antibiotics. This is a CT scan of the patient. Now the ET aspirate of the patient grew Candida colony count of more than 10 to the power of 5. The blood cultures are negative and the patient is stable. What will you do at this moment? Start fluconazole, start echinocandin, start liposomal amphotericin, none of the above. Yes, the correct answer is none of the above. This is because the Candida colony count of more than 10 to the power of 5 is from the ET aspirate. It is from a respiratory specimen. So a sputum specimen, tracheal aspirate, ET, BAL showing a BYC or a Candida is colonization, especially if the patient is stable and not running any, there is no stable, not having fever, no hypotension or signs of infection or sepsis. This is because there is a very high prevalence of colonization of the respiratory tract with Candida, and Candida lower respiratory tract infections is very rare, requires histopathological evidence to confirm the diagnosis. Now, this is very important, how to interpret positive cultures and not treat, right? So remember that just if the patient is stable and it's only the respiratory specimen which is positive, this is a colonization and antifungal therapy should not be started. Now we will move on to another case, and this is my dear friend who's focusing, and you will also need to focus a little like this. This is a 66-year-old gentleman with diabetes and a HbA1c which was around 9. Now this patient presented with a right MCA infarct. There was a left-sided hemiplegia. Now he was admitted under the neurosurgery department, and as a part of pre-operative evaluation, he underwent echo, which was normal. The creatinine was normal as well, and he underwent surgery, a decompressive craniotomy, as we can see here. Decompressive craniotomy was performed, and this patient was initiated on meropenem and vancomycin. Now, subsequently, this patient had 3 days later, after undergoing the surgery, he started having leukocytosis. The counts went up to 25,000, and the blood culture report was now available, which was Enterococcus faecalis. And that's when an infectious diseases reference was sought. So on Mirovanco, there is leukocytosis, patient is spiking fever, and the blood cultures are positive. So based on the susceptibility of the Enterococcus faecalis, we started this patient on ampicillin with gentamicin, and we requested to procure for ampicillin so that we can shift later to just ampi-genta for the Enterococcus faecalis infection. And as infectious diseases physician, we do not just treat a positive culture, we go back into the history. And this patient's history revealed that he had developed transverse myelitis, for which he was also receiving steroids, and because of transverse myelitis, he was also having constipation. Besides this, there was a significant history of fever for the last 20 days. For 20 days, he was running fever, and then he presented with a stroke. Now, this history definitely gives a clue towards a more deeper infection, and not just it's beyond just a positive blood culture. So we requested the neurosurgeon to kindly consider repeating the 2D echo, or we must do a TEE to rule out vegetation and infective endocarditis. And that's when the repeat echocardiography was performed, there were these kissing vegetations found on the mitral valve. So this was a case of mitral valve infective endocarditis with Enterococcus faecalis, who had then developed the MCA infarct. Now, this patient on ampicillin and gentamicin had started responding. There was a decline in the WBC count. His fever also resolved, and he was extubated. Now, during the next 2 days, we observed that the progressive decline in the WBC count was not continuing. In fact, the WBC count was going up, and um, in the rounds, the patient, since there was this extubation was done and a tracheostomy was performed, while just taking the rounds, the patient had a little cough. He just coughed like. So that just gave us a clue that, is there a lung infection or a pneumonia which is developing? So there was a strong suspicion of ventilator-associated pneumonia here in this patient who had a recent procedure and has been extubated as well. And there is subtle cough and the WBC count is not going down. Now, to confirm our suspicion, we performed the CT scan chest, which showed that there was indeed a consolidation which was present. So there was pneumonia on the left side predominantly, and the LRTI biofire panel, which was sent, detected Klebsiella pneumoniae, which was NTM and OXA48. Subsequently, the tracheal as well as the blood cultures which were also performed grew carbapenem-resistant Klebsiella pneumoniae. So this was significant colony count and the blood cultures were positive after just 33 hours of the incubation. This was a susceptibility which shows that this is meropenem resistant, which was an intermediate resistance to colistin with a high MIC of 2. So this was difficult to treat NDM OXA48 Klebsiella pneumoniae. It was susceptible to fosfomycin, so this was the only susceptibility which was reported. Now we requested for the synergy in this patient who is already on AMPI Genta and now has developed NDM OXA48 carbapenem resistant Klebsiella pneumoniae. We chose not to give a combination of cephalosporin avibactam with astronam, but because to reduce the pill burden, and we started this patient on ATM avi. So a combination of astronam avibactam was given, and to this the patient then subsequently there was a decline in there was improvement in his cough, respiratory rate, as well as there was a decline in the WBC count, and the patient was shifted from the ICU to the wards. However, during the course of therapy, he started again having some fever, there was diarrhea, which was noticed, and the CRP, which was reducing, started increasing slightly. Now, with this fever, and the fever had slowly increased to 103 as well, the question was, why is he having fever again? So, is it because of the infective endocarditis or failure of therapy of ampigenta? Is it because of the failure of ATM-AVI for the NTM OXA48 carbapenem resistant Klebsiella pneumoniae? Is it diarrhea? Is it a UTI which he has developed because he has a catheter, or is it something else? Now, since the patient is on Ampigenta and he had responded, the repeat blood cultures were negative for Enterococcus faecalis, so this was not the etiology for fever. He had significantly improved on ATM-AVI. The lung pneumonia had improved as well. Repeat X-rays also showed improvement, and the secretions from the tracheostomy were also not significant. What about diarrhea? Suspected C. difficile diarrhea, and we started empirically on vancomycin. The diarrhea also had reduced, but the fever was persistent. Now, with this, there was a suspicion of candidemia, and that's when we noticed as well that as part of workup, we had done the urine routine, and where it was showing budding yeast cells. The urine culture was positive for a E. coli, which was a ESBL E. coli. The BioFire GI panel was now available, which had confirmed our suspicion of C. difficile colitis. It was detected here. And here on 16th of June, where there was urine positive for the budding yeast cells, we also went back to the 4 days earlier urine routine, which had also shown WBC like pyuria, and there were these yeast cells which were seen. So initially we had discarded this as a colonizer and we had not started on any antifungal therapy. But when the patient was still having fever despite appropriate therapy for the other etiologies or infections and was having fever with a positive BYC in the urine, there was a strong suspicion of candidemia. So, what is the correct statement in this patient who is on broad spectrum antibiotics, having persistent fever with C. difficile colitis, ESBL E. coli in the urine culture, and there is BYC both in the urine as well as in the tracheal aspirate. So, the repeat tracheal aspirate actually had shown BYC as well. So, there was this multifocal colonization. So, which is the correct statement here? Urinary candiduria is a colonization and should be ignored and not treated. Tracheal aspirate BYC represents multifocal colonization. Fever is only because of the C. difficile. Fever is due to UTI with ESBL E. coli, which needs modification of the antibiotics and appropriate treatment. So the correct statement is this, that the tracheal aspirate BYC represents multifocal colonization and is in fact a clue towards candidemia in this patient. And I will explain why. See, generally, if there is a positive culture from the urine, it is urinary candiduria. Asymptomatic candiduria is not to be treated except in patients who are neutropenic or are undergoing urological procedure. But if a patient is having symptoms and despite having appropriate therapy for the other etiologies, urinary candiduria can be the first manifestation of candidemia and should be a subtle clinical sign to be picked up. Now, this patient was already on C. difficile colitis treatment and the diarrhea had also settled down. Still, he was having fever. So this fever cannot be attributed only to the C. difficile. What about UTI with ESBL E. coli? The urine culture was positive, right? But the patient was on ATM-AVI and ATM-AVI will cover the ESBL E. coli. Hence, this was not the likely cause for fever as well. So here the correct statement is that the tracheal aspirate BYC, it represents definitely multifocal colonization and with a positive urine routine and culture growing candida, it's a part of it is a clue towards suspicion for candidemia. So this brings us to the to this discussion that when should we suspect invasive fungal infections? They have to be suspected based on the clinical manifestations as well as the syndrome with which the patient is presenting. Now, for this, it's important to look into the risk factors of the host. So if the host is a neutropenic patient or a non-neutropenic critically ill patient who's having hypotension and is presenting with a sepsis-like syndrome, the probable fungus is a candida infection. And here, the drug of choice are the echinocandins. Fluconazole in stable patients or in mild illnesses can be initiated. However, we must also remember that in a ICU patient, I have also seen patients being stable and having just leukocytosis, and that can also be a manifestation of candidemia. The other fungi like Cryptococcus should be suspected in a HIV or a non-HIV patient who's immunocompromised, like cancer patients or SOT recipients, renal transplant recipients who are presenting with headache, meningitis, lung infections and skin infections. So there can be cryptococcomas. Aspergillus should be suspected in a patient who's presenting with sinus involvement. There are some lung nodules which are present, as well as sometimes there can be some eye involvement as well. So here predominantly sinus and lung involvement is in a patient who is having neutropenia, patient who's SOT recipient, HSCT recipients on steroids, immunosuppressants, COPD patients, patients who are critically ill in the ICU. Think about aspergillus and mucormycosis to be suspected in a patient who is having diabetes, steroids, post-trauma CKD hemodialysis patient presenting with usually a rhino or bitocerebral involvement. There can be a sinus involvement with blackish nasal discharge, that blood or epistaxis, pain, and on examination, eschar on the hard palate. Mucormycosis needs to be suspected. And of course, the other manifestations of mucormycosis can also be cutaneous mucormycosis, GI mucormycosis, cerebral mucormycosis, and of course, pulmonary mucormycosis, where the drug of choice is amphotericin B, but most important is the surgical debridement and the adjuvant therapy and control of the underlying risk factor. So as we can see here, the choice of antifungal therapy is specific for every fungus. So it's important to identify which fungus are we suspecting and then choose our antifungal therapy accordingly. Now, to arrive at our clinical suspicion of candidemia in this patient, which are the additional scores or tests which can be performed? So, as we know that the blood cultures have limitations, and even if we send 3 sets, the sensitivity of isolating a candida from the blood cultures is only 50%. That is why there are certain clinical prediction rules which have been created, and the most initial one was this Leon score, which was based on 3 parameters, which included TPN, surgery, multifocal colonization, and sepsis. And a score of 3 was associated 8 times higher risk of having a proven infection. But if you look at these parameters, patients who are going to be admitted in ICU will have sepsis, multifocal colonization, TPN surgery. So this was a very it would actually classify all patients to be having the likelihood for candidemia. So to be more specific and have a more specific clinical score, this Ostrowski's Genus criteria was also created, and this included an ICU stay of more than 4 days with antibiotic use and indwelling CBC with at least 2 of the following minor risk factors, which included surgery, immunosuppressants, pancreatitis, TPN, dialysis, and steroids. And this was further modified in 2011, almost 15 years back, that to this it was mechanical and ventilation for at least 48 hours, patient with CVC, and broad spectrum antibiotic use with additional risk factor, which included the surgery, immunosuppressants, pancreatitis, TPN, dialysis, and steroids. So any patient who is in the ICU is on steroids, is on antibiotics, will usually have a central line. And if there is mechanical ventilation for 48 hours with any of the minor risk factors, then the positive predictive value is 10%, but it has a very good negative predictive value of 97%. So this particular score can be used for identifying patients who are not likely to develop invasive candidemia, and this will help in the evolving antifungal stewardship. So we can avoid the unnecessary prophylactic antifungal drugs. The other biomarkers which can help us in arriving at the clinical arriving at the diagnosis after the initial clinical suspicion of invasive candidemia is the beta D glucan. In this patient, we performed it and it was positive, and in fact, beta-glucan, these are the non-culture based diagnostics which are adjunct to the cultures. It has a sensitivity and specificity of close to 80%. We must remember that beta-D-glucan, BDG, can be false positive in case of gram-positive and gram-negative infections, as well as in patients with who are on TPN, cardiopulmonary bypass. It can also be positive for other fungi like the Aspergillus, PCP, Fusarium, Trichosporon, and it is not just only for invasive candidiasis. Now, with the clinical suspicion, we had started the patient on echinocandins, and there was a magical response. From 103, the next day, the patient's fever had dramatically reduced to like 99 or 100. And they, as you can see, in over the next 3 days, there was a decline in the WBC and there was a decline in the CRP as well, and the patient was discharged. So it was the clinical suspicion and clinical correlation of those subtle positive results like a urine routine, a tracheal aspirate, and the entire clinical picture, which had the suspicion for candidemia. And then we started the antifungal therapy. And of course, the blood culture, the biomarkers were done, which turned out to be positive. The blood cultures, despite sending 3 sets, were negative. So it's very important that we give emphasis to our clinical acumen and also pick up the subtle clinical signs which will help us in arriving at the diagnosis, starting the right treatment before the test results are available. And the take home message is that candiduria is definitely a colonization which is very common in the ICU, and in asymptomatic patients it is not to be treated, but urinary candiduria can be the first manifestation of candidemia. And if there are multiple sites which are positive, that is, if there is multifocal colonization in a patient who is not responding to the antibiotics with despite the appropriate source control, this can be a clue towards the diagnosis of Candida infections. And that is why clinical interpretation of the lab investigations is essential. So now I will move on to this case. This is a patient who had presented to us with breathlessness on exertion, and he was having a WBC count of around 3000 with anemia. His CRP was very high, so that's a biomarker. 155 was the CRP, and the ESR was raised as well. Now, the chest X-ray showed a right-sided pleural effusion, as we can see here, and he was on meropenem and amikacin and still having fever and breathlessness, and that's when he was referred to us from Rajiv Gandhi Cancer Institute in 2021. Now, when we reviewed the history, this was a 31-year-old boy from Delhi NCR, and he was suffering from B cell ALL on maintenance therapy with dasatinib. He had a relapse, and that's why he was started on again chemotherapy, a revised chemo with ponatinib 45 milligrams once daily. In May 2021, he was admitted with febrile neutropenia and he was initiated on meropenem and amikacin. Despite having persistent fever, when they evaluated, he had developed right-sided moderate pleural effusion, which was exudative, and initiated on caspofungin for 14 days and stopped the therapy once he had a clinical response. However, a few days later, he again got readmitted. There was fever, there was effusion. Initially, meropenem amikacin was given as he was and then subsequently caspofungin was also started, but he was having persistent fever. Now at this point he was also having dry cough, and when we looked at the blood markers, his the CRP had increased from 2.4 to 1. So as we look at the biomarkers, the biomarker had become normal in between, but it had gone up to CRP 155. So we performed, since he was having a dry cough, the CT scan chest was also performed, which revealed that there was a significant moderate pleural effusion. At the same time, there were these nodules which are also present in the lung. And the right-sided pleural effusion was tapped, which had shown that it was exudative. And in fact, there was this Candida dubliensis, which was isolated, which was susceptible to fluconazole, voriconazole, and amphobe. Now, his serum galactomannan was also performed as he was having these nodular lesions in the left upper lobe, which was 4. So this goes in favor of a patient who has got probable invasive pulmonary aspergillosis. Along with, there is Candida dubliensis right-sided empyema. So there is a dual infection. There is a mixed IFI with Candida as well as with invasive pulmonary aspergillosis. So which of the following is the preferred antifungal agent in this patient? Combination of a liposomal amphotericin B, echinocandin, voriconazole, posaconazole, or a combination therapy of liposomal ampho B with voriconazole. Remember, this is a patient who is having fever, who is having breathlessness, but he's coming to us in the OPD. He's not really admitted. So in this patient, to arrive at the at which antifungal agent we must use, we should be also aware about the epidemiology of the invasive pulmonary aspergillosis. He has a probable IPA, but we do not have any cultures positive. Now, the most common aspergillus species in India is Aspergillus flavus. In India, worldwide, it is Aspergillus fumigatus, and that's responsible for 80% of the IPA. But in India, it's Aspergillus flavus and fumigatus, which are almost at par with each other. And it is because of the hot temperate climate and maybe because of the construction activities. And flavus is also responsible for the sinus and the skin and soft tissue infections. The other species like Niger, Tedious, and versicolor are come are lower in the order. So the knowledge about the species and their prevalence comes from this particular uh, publication from FISF, which is regarding the epidemiology and the clinical outcomes of invasive mold infections in the Indian Intensive Care Unit. And here they showed that the prevalence is close to 10 cases of invasive mold infections per 1,000 ICU admissions in the Indian ICUs, and that is contributed because of the high spore count. The Aspergillus species, which is most common, is Aspergillus flavus, followed by fumigators, and it's the Aspergillus species which is contributing to close to 82% of all the invasive mold infections. The other molds which are common are the Mucorales, Rhizopas, and the other species like Fusarium, Carvularia, and other invasive mold species. Now, why is it important to know which species of Aspergillus are we dealing with? This is because the antifungal agents like the Vori liposomal ampho B or amphotericin B, they have different susceptibility for the different species of Aspergillus. Voriconazole has a high activity against both fumigators and flavors, and also for the other species like the Tedious and the Niger. But liposomal amphoby has got high activity for the fumigators but has only partial activity. The Aspergillus flavus species has a higher MIC for the amphotericin B. So here again it's the azoles which will be the drug of choice. And if in our country it is flavus which is more common, then of course for invasive pulmonary aspergillosis, azoles will be the preferred agent over amphotericin B. Amphotericin B can be preferred if we are also suspecting some other fungi or an invasive mold infection together with the IPA. So mixed IFI, liposomal amphoby can be preferred, but if it's only IPA, then azoles are the drug of choice. There is resistance among the Aspergillus species, both intrinsic and acquired, and the intrinsic resistance is to amphotericin B is seen with the Tedious, Nidulans, and with the flavus, and acquired resistance to the azoles among the Aspergillus species, maybe Aspergillus fumigatus is also noticed, but it is probably to the tune of just less than 2% and is because of point mutations in the CYP51A gene. So now this brings back to our question that in this patient who has got invasive pulmonary aspergillosis and has got a right-sided pleural effusion with candida, which is the preferred antifungal agent? And the answer is that it will be voriconazole, which will cover both invasive aspergillosis as well as the Candida dubliensis empyema. Echinocandins, they are good for candida, but echinocandins also have a poor penetration into the pleural fluid. And besides, echinocandins have only static activity against the invasive aspergillosis. They act only against the growing hyphae, have static activity, and are not cidal for the aspergillus. They're cidal for candida, not for aspergillosis. Coming to liposomal amphoby, can we use this? So liposomal amphoby will cover um, candida in this case. However, for aspergillosis, if suppose it is flavus, then flavus has higher MICs. Again, liposomal amphoby is intravenous, requires a peripheral venous access. It's very expensive and as well as toxic. So looking into all these accounts, we started this patient on voriconazole, and voriconazole was initiated, and ponatinib 30 milligrams OD was continued because of the in this patient the dose was reduced, and then subsequently the patient became better, fever resolved, he was afebrile, and he was also discharged in the stable condition. However, 10 days after the discharge, he came to us again. He was breathless, and this time he is only on voriconazole. He was not having fever, but when we looked at the X-ray, there was an increase in the pleural effusion. So, what do you think is likely in this patient? Whether he is having a breakthrough invasive fungal infection on voriconazole? Is it a superadded bacterial infection? Can it be both, or is it none of the above? So let's discuss this. Now, the clue here, the clinical clue here is that the patient had no fever and he was not toxic. He was breathless because of the effusion which had increased, but no fever goes against a bacterial infection. So the approach would be, if there is a pleural effusion, whether it's infective or it's non-infective, whether it's because of the bacteria or is it because of the drug. So no fever, so there is very less likelihood of a bacterial infection. Because the patient was on voriconazole, which would cover the candida and also the IFI, the possibility was less that it is failure of therapy. And since the patient was not toxic, the other infective etiologies were less likely. So we also looked into, and we thought that is there a possibility of ponatinib related pleural effusion, and is it because of any drug interaction which is happening with the voriconazole? So first we looked into the side effects of ponatinib, and one of the adverse effects of ponatinib revealed that yes, pleural effusion is very much possible in close to 20% of the patients. And with this we looked into the interactions, and Vori and ponatinib have significant interactions. The voriconazole increases the levels of ponatinib by inhibiting or affecting the CYP3A4 enzymes. So even though the dose has been reduced to 30 milligrams OD, which is recommended, but since the patient is having a right-sided pleural effusion which is increasing, this could be the effect of higher levels of ponatinib. Now, if voriconazole cannot be used, what is the other drug which can be used in place of vori? Can we use the other azole, posaconazole? So the posaconazole and ponatinib also have interactions, and both increase the levels of each other by affecting the hepatic intestinal CYP3A4 enzymes and their metabolism. So we looked into the other azole, which is the isavuconazole, which was recently launched in 2021, and there were no interactions. So this patient was switched from voriconazole to isavuconazole, and this was initiated. He was continued on ponatinib, and within a few days, there was resolution of the pleural effusion. So while there were concerns that this patient should undergo um, bronchoscopy, or there is a wrong diagnosis, but it was the drug interaction and the higher levels of one of the drugs which was resulting in the pleural effusion. And this clue came from the clinical interpretation of the symptoms of the patient was clinically not toxic. That was very important. So we must emphasize on the clinical history, presentation, the clinical examination of the patient, which can actually help us in avoiding invasive procedures as well. And it will also help us in utilizing, optimizing our antifungal agents. And this we had published in the FISF newsletter, which is being edited by Dr. Tanu Singhal. And this was this management of dual invasive fungal infection as well as pleural effusion in a patient with relapsed B-cell ALL on ponatinib. And we have emphasized on the interactions of azoles, the various drug interactions. Isavuconazole definitely has lesser drug interactions as compared to vori and posaconazole, and this becomes very important in clinical practice. And these subtle clues are important, and they will help us in the appropriate use of antifungal agents, which will help in the evolving antifungal stewardship. And this is my ode to our mentors and the pioneers in infectious diseases who have definitely taught us the basics. Thank you so much.